is Cambridge. Please keep your bags and personal belongings with you at all times.
Okay, so this is the Wolfson Brain Imaging Centre. We were built in 1996. We're part of the University of Cambridge, and we image predominantly for research, but we also do quite a bit of clinical work as well for Addenbrooke's Hospital. So through this way, we have the PETMR scan. So this is a hybrid PETMR.
Oh, nice.
This was we brought this into the RIBIC in 2016, 2017. Used it mainly for neurology, but we also do some oncology as well. We also have a Hyperpolarizer attached, which makes it quite unique actually. So we are very fortunate. We have a radiochemistry department downstairs, so we can produce novel tracers.
Right.
We do quite a bit of carbon-11, so 20-minute half-life. You know, we need it to be upstairs quite quickly to inject into the patient.
Wait right there. SignalBot. Tell us how hyperpolarization works.
Hyperpolarized MRI is based on the premise that cancer cells use and metabolize nutrients differently, and often at a faster rate than normal cells. Prior to the procedure, the molecules of the solution are oriented to an MRI's magnetic field at an extremely low temperature, hyperpolarizing the solution, so that the normally very weak signal emitted by the substance is much stronger. The patient then receives the solution through an injection, and as the body processes the substance, doctors get a quick snapshot of whether the cell's metabolic processes are indicative of cancer.
Oncology, so we do some pancreas, some ovary, renal, liver.
Okay.
But we do a bit of cardiac imaging.
Oh, nice.
I've been a radiographer since 1995.
Nice.
So I trained in the north of England, and I moved here to the Wolfson Brain Imaging Centre in the summer of 2000. So I've been here quite a while.
Nice. What's your favorite part of the job?
Oh, that's a tricky question.
I know, right?
So I do like patient contact, but as a manager, obviously, I don't have much patient contact now, although I do try and spread myself quite thinly and help on all platforms where required, just to make sure that we've got, bodies on the scanners to make sure we can have income, ultimately. Sure. We're a major research facility, so it's really important that we do get income through. For sure. Yeah.
And you guys are doing inpatients and outpatients as well as research.
So we're predominantly research, although we do have a proportion of our work that we're now helping the NHS in there. We've been helping the NHS since we had our refurbishment in 2016, but even more so now post-COVID. We're helping them through. We did a lot of the imaging through COVID. In fact, we did, because we didn't do much research during COVID. That all stopped, although we did COVID research, but we didn't do anything else. So we were actually available to help, and the way that everything worked out, they needed access to more scanners rather than anything else. So we did a lot of neuroimaging during COVID of the critical care patients. So my staff were all, fully gowned up and doing all the imaging here, which is great.
It is great.
And then helping with the recovery plan now moving forwards.
But also, this is such a huge campus. Of course, me and Robert kind of got lost trying to navigate a little bit. But, man, we'd love to see more of the facility for sure.
Yeah, sure. So let's, obviously this was the PETMR, so we'll go around the corner and I can take you around to show you the MRC. So this is the Prisma Fit. This was installed in 2016. This is one of our workhorses, if you like, for functional imaging for research. So we have attached to this, we've got projector, we've got various other stimulus delivery kits, so we can do auditory, we can do visual. Some studies give electric shocks during scans. Various things we do during research. Some things we administer fluids, so they can actually drink a little bit, to look at reward systems and satiety and things like that. We do quite a bit of psychology research. But yes, so this is also where our acute brain injury program runs from as well.
Oh, nice.
So the patients were literally just adjacent to the neurocritical care unit. So the patients can come through this way quite easily and low risk. So they don't have to traverse the rest of the hospital to get to the clinical MRIS department.
Oh, that's nice.
So they can come to us where we can look after them. We've got all the ancillary kit that we need to set up and scan them safely. The ventilators are conditionally safe in the scanners.
Awesome.
And we can also impressively monitor their ICP whilst they're in the scanner as well, which means that the clinicians feel much happier now that they know that,
Right.
intracranial pressures are monitored and safe.
Exactly. Now, when you guys are doing your functionals, who's kind of working up that data?
So
Is it
the
the radiographer?
radiographer will take care of the participant.
Okay. Like
So the radiographer, so the participant might be a patient or it might be a healthy volunteer.
Okay.
And of any age from 0 to 100.
Oh, nice.
Reasonably. Healthy
Right.
volunteers tend to be Cambridge undergrads, to be honest.
Right,
So
yeah.
the population's maybe a little bit skewed with IQ wise. But no, the radiographers will do the imaging. The data then gets sent to a secure hub
Okay.
where the researchers can then access their own data in a pseudo-anonymised format.
Oh, I see.
And then they will be responsible for their analysis
Right.
pathways, because that's also reasonably because most of the research somebody's doing a PhD on it.
Hold up one more time. Signal,
What?
can you find a cool research study performed by Cambridge using fMRI on brain injury patients?
Here's something. Doctors Martin Coleman and Dr. Adrian Owen out of Cambridge have demonstrated in a seminal science paper that fMRI paradigms can detect awareness in patients who are behaviorally meeting the criteria defined as a vegetative state. Clinically, the patient investigated demonstrated no evidence of awareness or purposeful response to command when she was asked to move or speak. However, when asked to perform several mental imagery tasks during fMRI, the responses obtained were indistinguishable from healthy volunteers performing the same task. Hence, despite negative behavioral markers, it was possible to detect awareness without requiring the patient to move or speak.
And so it's their responsibility to analyse and write it all up.
For sure. And I know one thing that's really, really important, of course, in research is you want to kind of have some sort of reproducibility, right? Because you don't want to.
Completely.
It's got to be standardized. So how do you minimize the variability between, I guess, and I want to say technologist. I'm trying not to say technologist.
That's all right.
Radiographer from the next.
So we have very strict SOPs. So, operating procedures.
Right.
So the protocols are all hard programmed on the scanner. Mm-hmm. So everything we do is by protocol number. So everything has ethics, everything has insurance, everything has research and development agreements and approvals in place, and of course funding in place.
Right.
Once we've checked all of that's in place, we can do the study. So we then issue a protocol number.
Okay.
So all those protocol numbers, the same protocol number is used on the scanner, so that we know that that protocol, this is what we're running. Nobody touches the parameters.
Right.
Unfortunately, we don't lock it down. You can lock things down on Siemens, but if you're
Password
unlocking
protected
it,
or something.
but everybody needs to know the passwords. They need to unlock it for everything else. So it seems a little bit.
They'd be calling you all the time, Vicki.
I know,
Password's not working.
Yeah. So everything we train really hard.
Right.
Everybody understands. Everybody knows what to do, and we've got written SOPs on what to do in each of the sequences. On the angulation, on what sort of shim's required, on what paradigm is required at that time, and even down to the researcher may even have set script that they use to speak to the participants. So everything is as reproducible as possible.
Very standard.
But there is still a small amount of subjectivity because she's changing staff.
Right.
But we do have some studies where there is a problem with subjectivity, where we've got some studies that have got quite a lot of intricate shimming or intricate knowledge on positioning and reproducing that positioning for their second and consequent visits, then we will have named radiographers on that study, and we'll try and remove as much subjectivity as possible.
Nice.
But it's a good question.
Yeah. And two, how close to contact are the clinicians? Say if you are having an issue and you just want to kind of reach out to somebody.
So part of our process is we make sure that there is somebody at the end of a phone or the end of a bleep if we need them. Some of the studies, the clinician is actually the person doing the PhD, so they're already with you.
Right there,
which is great. And they tend to be the ones that they do like to be very involved, and they're really involved in positioning of voxels and things for spectroscopy.
Nice.
But yeah, we do a little bit of that.
That's awesome.
Yeah.
Nice.
Perfusion imaging, permeability imaging, you know.
Right.
Do a bit of stroke imaging. Acute stroke is a tricky one to try and get.
Right, and you're saying this is one of your TBI scanners, right?
It is, yeah.
So do you guys do a lot of DTIs?
Oh, absolutely.
So many,
DTI,
right?
yeah, absolutely. we do an awful lot. We've got some DTI queens and DTI princesses that work in Cambridge. You know,
awesome.
so yeah, absolutely.
Absolutely. What's the strangest location that you've done a DTI? I guess, have you done any spine DTIs?
We've done a little bit of cervical spine DTI, yeah. Right. And we're doing a study at the moment actually looking at that pre and post surgery.
Awesome.
Yeah.
That's kind of tough, right?
Yeah. So we've also got a 7 Tesla through the door there.
Oh, yeah, 7T. We'd love to see 7T. When you're doing the screening form, is it paper or is it mostly digital?
It's paper.
Paper, okay.
So we have the same screening form we use for participants, for staff, for patients. Everybody uses the same screening form, so there's no disparity about that.
Right.
The only difference is, of course, we have a tick box at the top, just like they do in Oxford, where it says one's 3T and one's 7T, so we know which we're approving.
Wow.
Because, of course, if we're signing off a screening form for 3T, that doesn't necessarily mean that they're safe to go into 7T.
Exactly.
But we do make a point of getting everybody changed into scrubs before they go into 7T. So we did find very early on that there was quite a lot of swarf from the street, you know, just little bits of tiny bits of micromaterials that come off your street clothes. So we have a sticky mat that they have to walk across before they go in.
Nice.
And then we put everybody in scrubs, so just down to underwear, but removing bras, obviously, and popping people in. So the scanner bore is 60 centimetre diameter, same as your Prisma. So it's a little bit longer. But we found that most people tolerate it very well.
Not too bad.
So obviously the only thing is you'll have to take your mic off and everything.
Oh, yeah.
So if you don't mind, this is our screening form just here. It is quite detailed, but bearing in mind that this screening form is also for our critical care patients who may be, you know, a John Doe that we don't know who they are. Oh, for sure. So we have to go with everything else. Do you have to get changed there? There's a changing room just here.
Okay, sorry.
There he is.
All right, I'm sorry about before. Get a little too excited about these type of things.
So if you want to just complete the screening form,
Yes, ma'am.
if you haven't heard of it, generally you probably haven't got it, but we can discuss it.
Do you find that tattoos tend to be a problem at all in this?
So that's a good question. So we've there is a paper that was published in Germany actually looking at tattoos in 7 Tesla. Which we've taken information from that and taken our risk assessment from that. So when we first started imaging here, we did say that, you know, the tattoo, because of the RF coil has a little bit of additional heating beyond the perimeters of the coil. Right. So for the heating, if you've got tattoos in those areas, the risk is that they could heat up, obviously, and they could have a bit problematic. So to begin with, when we first started imaging, we were doing the cutoff was at sort of mid-chest area. But now the cutoff is at the shoulders, so we're happy to scan people if they've got tattoos on the trunk, legs, and arms, but not if it's on the neck or head. Okay. So we cut off for that.
What about coloured contacts?
Contact lenses?
Yeah,
no, not coloured ones. No, we don't. Not on any of the scanners.
You don't allow it, or you're not concerned for it?
No, we don't allow it. Sorry. So we actively encourage people to wear contact lenses if we're doing functional imaging with visual stimuli.
Oh, nice.
Because, I mean, we do have corrective glasses, but, you know, the glasses, once you've got them in the scanner, you've got quite a restricted field of view.
Right.
Whereas if you put somebody in if they've got contacts in, it's much easier for them. Sure. Although, because of the scanner and because of the airflow, they do tend to get dry eye quite quickly. So we have to think about how long they're going to be in the scanner for, etc.
For sure.
So,
now,
let me just have a quick...
Okay. Coils, you guys are mostly doing neuro and knees?
Mainly neuro. We've got a knee coil as well. We've also got a physics team that are looking and developing new coils.
Oh, nice.
So there's a cardiac coil being developed as we speak. So that should be something good. But yeah, I mean, mainly it's but we've got both the PTX and the single TX on here as well. So we've got both systems here, so we can do parallel transmit imaging, and we've got the whole multi-nuclear package as well. So we've got a number of different coils in there for various different nuclei. So we can do phosphorus, carbon, sodium, and deuterium imaging.
That's awesome. How hard is it to switch between multi-nuclear? Like when you're going from one, to the other, is it separate protocol, so it's a completely different workflow, or is it just a drop down?
It's quite reasonable actually. It's not too problematic.
It's not problem at all, huh?
Yeah.
Okay.
There's still a few teething issues occasionally when switching between the 1TX and the PTX.
Right.
But Siemens are aware of that. So,
Right. Okay.
Yeah.
Nice.
But yeah, I think it's a very good machine.
Yeah. No,
Very happy with it. I mean, this was the first one to come into the UK. So we took this one, it was the first off the conveyor, but in fact we took it before the covers were ready, so it came under tarpaulin, in secrecy.
Right.
And they carried on building it on site once it had arrived. So that's quite cool. So,
Yeah.
I'm
Let's do
gonna
that. All right. Anything I should be aware of that I might experience?
in a 70, I'm going to have to set my mic off to go in, by the way. But,
yeah.
the 70, once you go into the scanner, actually, you might find that you feel as though you've had one too many shots.
Oh, really? Okay.
That's about it, really.
I'm a lightweight.
Some
too.
people.
Basically.
I don't want to suggest how you're going to feel, because if I suggest it, the power of suggestion is almighty, isn't it? So,
right. Yeah.
so let you tell me what you feel when you come out, and I'll tell you if that's the same as everybody else feels. So,
For sure.
I just have a metal detector.
For sure, I think a little bit just going in. My heart was up, and I'm just so excited about this whole experience. And so, thank you for letting me have that experience. For sure.
You're welcome.
Did
you feel as though you twisted round at all?
Yeah. So once I
round to
first
the
started going in, I did kind of see like the vision just kind of start. It felt like it was like doing this kind of wavy thing.
Right.
And then on the way out, I kind of closed my eyes, and I could kind of see kind of like an aurora or a lure of color, like it's like an orange.
You thought so you had phosphenes, did
Yeah,
you? Really?
yeah.
Oh, okay, I was so nervous you
huh.
reported that, so that's very interesting.
Right.
Okay.
But it was not nearly like you. I've read so much about 17, the precautions that you have to be ready for, because we're getting ready to get one in our department, and I'm like, oh, you're gonna get nauseous, or I'm gonna get dizzy in there.
Yeah.
I'm gonna, this, and it was nothing like that.
No.
Nothing like that. I got a little weird taste in my mouth, but outside of that, it was great.
I think you'll find the more often you go into the scanner as a part, certainly I've found the more frequently I've gone in, the less the side effects are.
So the body just kind of
So you
adapts.
kind of adapt to it, yeah, sure.
Right? It's just another level of gravity.
Yeah,
right?
it is. And bizarrely enough, the way we were talking about, you feel at the back of the 3T when you put your head in prone. You feel a bit of dizziness there and a bit of metallic taste. It's not as obvious in the back of the 7, but you do feel it going into the 7.
Well, yeah.
But yeah, so you can put your head in a little bit. It doesn't feel as disorientated in the back. So it's it's awesome. Interesting. So what scanner are you getting?
So I believe we are getting. I know it's the Siemens 7T. So maybe
it must be the Terra then.
Yeah, it must be the Terra.
Which is already CE marked, which is great.
Yeah.
So ours isn't CE marked.
Right.
Because we got the first
You
one.
guys opened it up for all of us, right? Yeah, thank you.
I did a little bit of work. I mean, when we first had it, we had to do a lot of work with Siemens because there were no sequencers on it.
Oh wow!
So literally, it was quite a lot of work just to get the basic sequences going.
What do you think the hardest part of that transition? Just being an early adopter like that, do you find like there's a lot of bugs?
There were, but I wouldn't say it was hard.
Right.
It was more enjoyable at the fact that we were able to work closely and we were able to see development as radiographers. Right. It meant that you could actually learn a bit more and understand a bit more of what's going on in the background.
All right.
And have your input as well, which I think is super important for radiographers.
Right.
We do a lot of imaging, and if we don't do a lot of the post-processing of the research stuff.
Right.
So it's nice to be involved at some stages.
It is cool, and back home we call ourselves technologists, as we've talked about this several times, and this is my spiel that I give everyone that asks why I get into it. It's like, I consider myself a true technologist because I love technology, and I believe like this type of stuff, just the way that MRI advances, is one of the most exciting parts of the job. So just to be on the forefront, like you guys are doing, I can only imagine the excitement that you guys get from it.
Cutting edge research is, it is exciting.
Right.
And I love to see things that we've done in research and then to see the true clinical translation.
Right.
That's to see the effects that you've had on somebody's clinical care pathway, whether it be to improve the diagnostics or to facilitate speedier diagnostics to improve better outcomes and things, or to watch and monitor how their drug response in research or their chemotherapy. I think that's all fantastic. We also do a lot of psychology stuff as well, which has input into drug development and if the drugs work, and in pharma companies and things, which is equally exciting.
Right.
But there is still that mundane side of research because everything has to be exactly reproducible. For 80 participants in one study, you have to do exactly the same thing. You can't change anything. So that side of things, it does become a little bit mundane for the staff. So you have to ensure that they've got lots of other things to keep them occupied and to keep them interested. And having input in the start-up of studies is one way to grasp their interest and to satisfy their hunger.
Do you feel like they kind of rely on you guys to give input on how you guys are kind of progressing some of this new technology?
Yeah, I think it's a good mix. We work we're a multidisciplinary team. We would be nowhere without our physics support. The physics support would be nowhere clinically without the clinical radiographers. So, there is a two-way stream, and one wouldn't be there without the other. So we do work really closely together, and that's how you do things, isn't it?
Yeah. Oh, me and Robert totally get that. Yeah.
In the whole world, if everybody was to work together beautifully, they'd reduce the animosity, etc. It'd be lovely.
For sure. That's one of the biggest things this podcast is about, is just sharing the knowledge across all MRI, whether you're a technologist, radiographer, physicist. I feel like a lot of radiographers kind of learn from other radiographers, so why not use a platform to kind of elevate that and just kind of spread the word? So, this is great. 7T. Woo! We mark that one off my bucket list. 7T SAR issues, because you kind of brought up SAR a little bit.
Yeah.
Does that kind of dictate everything for you guys?
A little bit. Yeah, it can be. We've worked very hard on some core sequences that we go to.
Right.
So we know what does work and what doesn't work. So we don't have to reinvent the wheel every time a new study starts.
Right.
So a lot of people play on previous knowledge. And we work with a fantastic group in psychology, and they had a bit of 7T experience before they came to us actually.
Oh, nice.
And they've been great in guiding us and helping us and in collecting data that we're playing around with the parameters a little bit, trying to make it as high resolution as possible so we can see fine detail. And they've been absolutely critical in doing that evaluation of the data and telling us whether it's good or not.
For sure. Have you found, especially on this level of field strength, easier to navigate some of those issues with the B1 RMS factor versus using SAR? Or have the physicists not really looked at that too much?
I think they've not shared it if they have done.
If they have, okay.
Yeah, they probably are well on top of things.
Right. Okay.
Yeah,
Well,
we've got there's quite a big physics team actually doing lots of things. So
that's awesome. And you learn so much seeing the big picture, working with physicists, and I can only imagine the type of big picture imagery that you get from working in such a great facility like this, cutting edge. So you get applications, you get physics, you get the radiologists, you get great radiographers.
We do.
Man.
Yeah, we have it. We're very fortunate.
Yeah,
very
awesome.
fortunate. Yeah.
Man, Zone 3 might have to move in.
I say, send your CV.
Well, Vicki, thank you so much
You're very
for giving
welcome.
us this opportunity, helping me, mark some things off my bucket list, and giving me and Robert this opportunity to just check out how cool it is to be at a Cambridge research MRI facility.
You're very welcome.
This is great. It's nice to meet you.
Thank you.
Yeah, thanks for
Good
tuning
job.
in. Zone 3 Podcast. We are out.